My name is Lauren Marcoux, and my presentation today focuses on inpatient falls and possible interventions to minimize or prevent them. More specifically, TIPS, which stand for Targeted Intervention for Patient Safety. A little bit about myself. I currently work as a registered nurse on a progressive care unit at Trinity Health Ann Arbor, where falls have been a problem, which kind of led me into joining shared governance. Shared governance, for those of you that don't know, is basically a committee that discusses patient quality care. We meet once a month. We report the number of falls we have on our units, the current interventions that are in place, things that are being trialed on different units, and the goals for the future. And that kind of led me to conducting some research and stumbling upon TIPS, which seems like a great intervention and financially viable. Why address falls? First, the financial costs associated with a fall. A fall, whether it's injury sustaining or non-injury sustaining, carries a significant cost. A fall, as defined by the Agency for Healthcare Research and Quality, is a patient's sudden, uncontrolled, or unintended downward displacement of the body to the ground or other objects. An article by Card and others in 2020 mentions that there are 3 to 4 falls that occur for 1,000 patient days, and about a quarter of those are with injury. Their analysis also suggests that nearly 30% of the falls are avoidable or preventable. A fall adds additional care costs regardless if injury was sustained or not. A non-injury sustaining fall accrues financial charges by having tests performed to rule out injury. A fall with injury is even more costly due to the tests performed but also the increased length of stay that is associated with it. Frampton and Wells in 2023 mentioned that a fall with injury increases the length of stay by approximately 6 days and adds an average of $14,000 to the overall hospital cost. A fall can also have emotional costs associated with it as patient becomes distrustful of the healthcare personnel. Significance to nursing. The American Nurses Association has established nursing quality indicators. Nursing quality indicators are distinct and specific to nursing and directly impact the nursing outcome indicators, which are influenced by nursing care. One such indicator is the number of falls. This allows for the opportunity to improve the number of falls by attempting to change in the provision of nursing care. As a profession, nursing has a duty to measure, evaluate, and improve practice. The establishing of NDNQI is a testament to the profession's commitment to improving practice. NDNQI is a national database for nursing quality indicators. It is basically the golden standard. Any hospital can use it to benchmark their own performance in different categories, including falls. The intervention. Before any intervention can take place, research must be conducted. A basic understanding of computer science is a prerequisite to anyone conducting research, as in today's time, most information is stored electronically. So an understanding of how to access it and how to easily distribute it or share it with others, it's essential. Staff must also be educated about why and how the interventions will take place, and then eventually the intervention must be applied, monitored, changed if things are not working the way they should be, and it's an ongoing process. Starting small. The book by Nelson discusses how a clinical microsystem provides care to certain populations of patients. The care is provided by a group of people who regularly work together. The clinical microsystem maintains the core aims and engages in processes and information sharing to fulfill its clinical and business goals. A clinical microsystem continues to evolve while still being embedded in a larger organization. A good example of that is a specific unit, which in my case would be the progressive care unit. To start, you have to start with team building. You have to have different members of the unit, such as a nurse manager, a clinical nurse leader, a nurse coordinator, and staff, like regular floor staff, such as a registered nurse, joining the team so they can they can identify the problem, which in this case would be falls, and they can also share their own individual thoughts and experiences, and which can lead to an intervention being tweaked to fit the system. The cost of the project on a microsystem scale, it's relatively very inexpensive. When it comes to tips, the cost will include additional time for staff members to come together and kind of brainstorm and come up with ideas and how they want to apply the intervention. And it will cost to print the actual posters that get placed on the patient's rooms, and follow-up meetings to track the progress of the intervention. Reinforcement is crucial at every step of the intervention. People need to be reminded that this is a change, this will be the new norm, and they need to be told that they need to see visual reinforcements. In this case, I decided we should put graphs of the number of falls we had in the month prior to the intervention and during the intervention, so they can actually feel like they are making a difference and that what they're doing actually matters. While implementing the intervention with tips, I had to kind of brainstorm a little bit to see how different things affected the people, such as new nurses, people getting floated from different units or being short-staffed. They could have effect on the interventions being applied. The process, the way we currently assess patients and how we document it, we currently use the Hester-Davis to indicate a patient fall risk, and then we have the care plans and the actual interventions that need to be in place for a patient not to fall. And there is continuous education in the form of health streams that gets provided to every staff member, especially nurses, including falls, amongst other things. Also, patient care technicians, or nurse aides as they're known in other facilities, they also play a significant role in preventing patient falls. They're the first to respond to the bed alarms or the patient call lights. Equipment also plays a role. Things such as bed alarms, gate bells, call lights. If those things are not working, you're not able to properly have all those interventions in place. If they're not in sufficient quantity, you can utilize them. Other things that affect patient falls are patient acuity, alarm fatigue, isolation rooms, room location. In other words, if the unit design is such that the nurse station and the patient room are too far apart, it will take a long time for a nurse to respond to it, and the intervention might not be as helpful. Or if there are a lot of patients on bed alarms and there's bed alarms going off at all times, alarm fatigue starts to set in. A follow-up needs to happen, as in any intervention. There's currently audits that take place every month to see the number of falls that we have. We have an internal reporting system that we call Voice. Basically talks about how the patient, like what happened, what we think happened, what do we think we can do better, or why we think it happened. And then those kind of get audited, and we do the clinical nurse leader and her peers do a root cause analysis to see if it is just like a nurse issue or there is a systems at fault. And then shared governance, which is basically, like I said earlier, we meet and discuss the number of falls, current interventions, future interventions, goals, and all that. The timeline. So when I was implementing this intervention, I utilized Gantt charts, as you can see on the left of the screen. This is basically the timeline that I used the intervention we started on 3/3/24, which the clinical nurse leader started auditing the previous month falls, and then the following week the nurse manager sent emails to remind the staff that this is what we're doing, which had been an expectation, but more like a reminder that we should still be doing it. Myself, I ended up doing the educational in-service, quick 5 minutes at shift huddle, just basically a reminder of why we're doing what we're doing and how to do it. And then a week after that, I was auditing the actual tips posters in the patient room to see if people are actually doing them or not. After that got done, the clinical nurse leader would then audit the patient falls after the intervention to see if we had any improvement or it actually got worse. And then at the end, the nurse manager would kind of share the information of what we tried. And we started on March 3rd and then finished on April 20th. Approximately took about 37 days. The Gantt chart on the right kind of helped to keep track of the progress that was being made in the project. You could see I kind of had them separated by the people doing what. Like I had like Akila, which is our clinical nurse leader, then Alyssa, which is our unit nurse manager, and then myself to kind of see which days in the month we're doing specific tasks and if we are on target. Any intervention that is successful on a specific unit can potentially be implemented on a broader scale. And this is what macro system is basically. It's a bigger system than the macro system. A clinical macro system is composed of microsystems who mesh together to address patients' evolving healthcare needs. It can be as small as local hospitals and as large as the country's healthcare system. Attempting an intervention to improve nursing outcomes at this level needs to be well planned and executed. The financial cost at this level eclipses those of the microsystem. It's a larger system. It's going to involve more people. It's going to cost more. Just getting people together from different departments, the additional time they have to spend there costs money. And then also the materials itself. If you're doing the posters, you have to produce more of them, which can cost more money. And then it comes down to if it's sustainable or not. Sustainability comes down to what the healthcare system's goals are. Yes, falls are important because the Center for Medicare and Medicaid Services does not reimburse falls and any costs associated with the fall. So that can be lost revenue for the hospital. So it's something that they have to address if they want to be sustainable. But at the same time, they have to do a fine job of prioritizing. There is only so much money that can be located to certain projects, including implementing tips, which in my opinion and the research that I've done, it's very sustainable from the financial side of it because it doesn't have a high cost of implementing. And then nursing informatics. Nursing informatics, it's basically a combination of computer science, information science, and nursing science, and they come together in nursing. It is an essential part of any successful quality improvement project. The data, information, knowledge, wisdom paradigm, it is the underpinning of the conceptual framework that translates into the science and practice of nursing informatics. It is important to understand that the DIKW paradigm is also used by other disciplines who process data information. Data helps identify the problem that needs to be addressed, such as falls in this case. They get reported we look at the numbers, or the nurse informaticist looks at the numbers. If they're going up, that's a red flag that we have a serious problem. And then the committees review the data, the voice reports, which the clinical nurse leader utilizes to kind of see if it is a unit or if it is a system-wide problem. We use electronic health records, so the informaticist can go and look at the patient's electronic health record to see if the interventions were in place, or they can use the nursing knowledge and wisdom that comes with it to see why certain patients do not qualify for certain interventions. Data remains the same, but the information that can be obtained from it depends on the context that it applies. A patient can have the same number in Hester-Davis, which is a scale that we use to assign fall risk, but for completely different reasons. And understanding that two different patients have the same risk, but can theoretically be at a higher chance for falls, is crucial, because the interventions that will be applied to it are completely different. Conclusion: falls continue to be a major problems in hospitals across the country, my hospital included, and specifically my unit. The onset of the COVID-19 pandemic made things worse. We lost a lot of staff, the patient acuity was higher, alarm fatigue was real, and a potential intervention that has shown promise in different hospital settings across the country is TIPS. I think doing it successfully on my unit and having the positive results that we expect can serve as a pilot for the whole hospital, and it can be expanded at the micro level, which means other units can also replicate it and make it part of their practice. Thank you for listening to my presentation. Any questions that you might have can be addressed to lmarcu@svsu.edu. Thank you again for your time.